now we are coming to the most severe complication in the field of total joint arthroplasty, and we have a really great panel, probably one of the best panels we can get about this topic. And we start with the acute one, then we have an interruption for lunch, and then we continue with the chronic ones. First of all, my disclosures again, my rules again. I'd like to start with a patient of mine. I operated him in September 2020, 56 years, former professional tennis player. Indication was really clear. He was completely healthy, very active, and so the indication here is clear. He needed a joint replacement, a hip replacement, and I did it in an uncemented way. He was fully mobilized, pain-free after 6 weeks. He resumed to tennis playing. He played quite well, and he was absolutely happy, and I was a hero in the tennis club.
Question is, was he a Wimbledon champion?
Sorry?
Was he a Wimbledon champion?
He was not really a champion, but he was quite good. So, but on the 23rd of December, just before Christmas, he called me because he developed since 2 days, severe pain in the right hip and fever. He felt really weak, and his CRP level was 280. So, Dan, let's start with you. In this situation, what would you do with your patient? Guevara arrived. Thank you so much.
Thorsten, remind me, how many weeks or months is he from surgery?
The surgery was in September. It's 3 months after.
Okay. Well, this is a tricky one, right? Because you haven't made it an easy, obvious case. And the reason it's not easy or obvious is that the symptoms sound like they're very acute, and yet it's in the fairly early postoperative period. So you're scratching your head. You're worried about it, whether it's infected, obviously, but you're scratching your head if it is infected and saying, is this an acute infection? Is it a postoperative infection that's been going on for 12 weeks? Which is it? Because it matters. If it's been a 12-week postoperative infection, probably you have to treat it as a chronic infection. If it's an acute, very acute infection, you might be able to get away with treating it as an acute infection and doing a DARE. So that's the thing that you're trying to sort out as you talk to him, understand the details, and then of course you obviously have to confirm whether it's infected first by doing the aspiration and so forth. Because sometimes they're not infected, they can be other things.
That's exactly why I've chosen this case, because it's a quite tricky one.
And would a CRP of 200 indicate more acute? Because maybe a post-op would be elevated maybe around 20?
Postoperatively, he was completely normal. CRP was below 5, so he was really in a fantastic shape. Alberto, patient comes to you 1 day before Christmas in this situation. What are you doing then?
So if he has fevers and chills, I'm worried. I want to make sure, take his vitals, make sure he doesn't have any indications of sepsis. I mean, you've already got the CRP, ESR, white blood cell count. White blood cell count is useful for a left shift just to complete the scoring system. Definitely getting an aspiration on him, definitely examining him, looking at the wound. If the wound looks good, that's nice, it's reassuring. And then obviously looking at his whole medical history, and then trying to send off the aspiration as soon as possible. Cell count, differential, culture. I wouldn't use any additional advanced analytics at this time. And if I have any concerns about his well-being, if he's coming from a distance, as some of our patients do, tell him to stick around, not to go home, stay around I would actually, even if it's in the morning, we're quite lucky. We can usually get the cell count and differential in a matter of hours. And then if we have that luxury, keep him around and then actually admit him to the hospital if I'm worried about an infection.
Let me be the devil's advocate. Do you really think, Vijay, you have a patient like this, 280, almost septic patients, do you would aspirate him? Do you wait for culturing? Do you wait for all the parameters? What you wait for?
You haven't told us how the wound is. Is he tender? Is there warmth, swelling, redness?
If he's septic, and also if he's septic, so I mean that's why you got to get vital signs on him. So if you got to get vital signs on him, you have
Pre-septic.
So you think he's in SIRS, if he has an inflammatory response syndrome, then what I would do is So here's the thing, if you're really concerned, get blood cultures, initiate antibiotics. That's the same thing, you gotta save his life first, and then admit him to the hospital. So you're telling me he's pre-septic, you don't like the way he looks somnolent, looks tired, you definitely don't let him go home. And at this point, if he's worried about it, get blood cultures that may be positive. You can still set up a hip aspiration, but at this point, you have to save his life.
Okay, and please about think about the three sentences rule. Guvara?
I go and completely clean it up the joint. The CRP is 3 digits. I don't have any other choice. No aspiration, no. Even if it comes on your marriage day, you still go in and do it.
Ed?
I would aspirate because if you have clear fluid, then I pause. If I see pus, that's it, he gets admitted to the hospital. That's the reason you do an aspiration, clear or turbid. Turbid, you're in the hospital right away.
Dr. Henry, you're not a surgeon, but what would you be
I would
your advice?
say clear or turbid, he's in the hospital anyway, given his symptoms. I mean, if he really is approaching he's in a pre-septic state, I mean, he's going to be infected. Whether he's an orthopedic service or not, I guess, is the question. I would also wonder, the distinction between, this is a post-op versus an acute infection. Either way, not all DAREs fail. And this is still a very early, it's a very early surgery, very short duration of symptoms. So and also you want to just save the person's life. So you might approach just with a DARE initially, try to salvage the joint. A lot is going to depend on the microbiology.
It was a Thursday, and he could really say it started on Monday. This is a situation. Okay, serum parameters. What do you need for serum parameters? Dr. Kumar?
I think you need to get a CRP done that you have already got. These are all acute inflammatory markers. So, if they are raised, and as everybody else has pointed out, you do aspirate, and if it is pus, of course, I think, and if it shows something, you can put him on antibiotics or just go ahead and do a debridement,
Dr. Henry,
sort of thing.
Do you think IL-6 would be useful in that situation?
Not in this situation. I think there's plenty of clinical information already that the patient is sick. I don't know what I would do with an IL-6.
Okay. So we had it, aspiration and acute infection. All of you agree, probably culture doesn't make any sense, but to make immediate tests like lateral flow tests, look at if it is pus or something that makes sense. So I think all of you agree with me, it's a quite acute infection. What would you do in this situation, Guvara?
A DARE.
A DARE. Ed?
I would do a DARE, and I would tap on the stem and cup. If I can get them out, I'll take them out. If they're solid, leave it.
Dr. Kumar?
I think DARE.
Dan?
Dare.
There's a possibility that it could be a post-op infection, but I'd give the benefit of doubt. I'll do only a DARE. I wouldn't do an exchange at this point.
Systemically,
Alberto, if this would be an acute infection, let's say 2 or 3 weeks after implantation, would you do a DARE or something else?
so with cementless components in the first 4 weeks, definitely if you can get them out, take them out, have the appropriate instrumentation, the threaded adapter, the slap hammer, take it out, and then do a 1-stage in this case. Definitely indicated.
You agree, Dr. Henry?
I completely agree with that. Yeah.
Wonderful. So, DARE. Let's talk about DARE. What are your indications for DARE? I'd like to ask you, Dr. Henry, first. Less than 3 weeks after implantation, less than 3 weeks after onset of the symptoms, less than 3 months, depending on the clinical symptoms, just gut feeling, like many surgeons, unfortunately, are doing it, or do you have no cutoff?
Well, I like the first 3. Those are the clear indications for DARE, but I think in practice it's a lot different. It can definitely be hard to even approach the patient and introduce the idea. In the U.S. usually it's a 2-stage, to approaching 2 surgeries, and especially if they've just had the implant done in the previous few months. That's a lot of surgeries within 6 months or so. So, I feel like DAREs are done, outside of the technical indications more and more often than they have been. And that's certainly reflected in the literature, I think.
Okay, that's the HSS opinion. Dan, what's the Mayo?
I think it's pretty close. I think that your first 2, less than 3 weeks after implantation, less than 3 weeks of onset of symptoms, almost all of them are going to get a DARE. The other time that we may do a DARE is with the implant that's just so destructive to remove that we're going to try to keep it and suppress the patient. So those would be the three main indications for DARE. And I will agree with Dr. Henry and others that we bend these rules a lot.
Yeah.
Based sort of on our gut feeling a little bit, and also sort of on the empathy for the patient. Let's not go for the huge operation right now, realizing that sometimes you lose.
Yeah, so another thing I would like to point, in India, within a month of symptoms. Second is that if there's no discharging sinus. And other thing is that, sometimes, it happens quite rarely, but sometimes, the histopath may show up tuberculosis. So, you can just go and debride the joint, and for tuberculosis, you start ATT, these patients get better. You don't require anything else. So if the implants are well fixed, right, and it's within a month, no discharging sinus, I think, one should go for a DARE, at least one shot.
Okay, one once. Ed, in California, do you have a strict protocol there?
We try to say, just like Dan, but I like to say one comment. If you have porous coated cup and stem and you have an exposed cup with pores, bacteria go through those pores behind the cup. Same with the stem. So if you have those type of systems, I'm going to go early, like 3 weeks, try to get those implants out because it's not as destructive. Then you use Alberto's wash, the 50-50, get that in, and then start over. Change the cup maybe 1 millimeter up, 1 millimeter up on the stem, and you start over, and it's not as destructive. So I'd rather be more aggressive on the front end, because if you wait, the 2-stage is more destructive than an early single-stage exchange.
Perfect. Gugale, you're a great surgeon, and how do you perform it there?
If it is less than, of course, my cutoff point in Indian practical point is less than 3 months. And I'll completely open the joint and completely take the liner out and hold on the cup and the stem and thorough debridement and pulsavac and close it with the vancomycin cement and antibiotic beads.
Okay. Yeah. And Alberto, some instructions for us? Sure. How do you really perform it there? What do you change, or what kind of, okay.
So certainly if it's an approach that you're familiar with and comfortable with, that's really where you're in the best situation. So obviously open up the previous incision, don't hesitate to extend it. First thing I do is go through the fascia lata, take multiple cultures. First thing I do, 5 different rongeurs, 5 different cultures, then administer antibiotics unless the patient's already got it because they're sick. And then from there, go ahead and assess the previous repair, take down the repair, and then really for me it's trying to find out where the normal soft tissue envelope is, inserting retractors to retract the tissue, and then you are doing a large capsulectomy. You're removing everything that you can. Everything that looks suspicious has to be removed. The debridement you do with a DARE should be the same as the debridement you do with a 1 or 2 stage exchange, removing anything that looks suspicious or bad. And then what I do is then, obviously, I actually like to do the debridement even before I've dislocated the hip, so I can see the entire mechanism, dislocate the hip, take the femoral head off, and then move the stem out of the way, continue the debridement, then take out the liner, continue the debridement. And then once that's all done, I then like to put in trial components, because then you've removed all this soft tissue. You have to worry about instability, all the things like that. Put in trial components, gate a stable construct, and then remove the trial components. And that's when I then go ahead and use rigorous pulsatile lavage, spraying everything, dislodging everything, and then utilizing chemical debridement, which we talked about yesterday, betadine and peroxide, full strength, leave it in there for a few minutes, and then while that's happening, you change your gloves, change a few of the drapes, do what you can to occupy yourself while you watch the clock tick for a few minutes to let everything die and get killed, and then you change your gloves and go ahead and put in the real implants. That's my step-by-step.
Oh, that was really very, Dr. Ed?
One comment I will say, I've made a couple mistakes, is that I always use now in a DARE an aortic cross clamp, make a small arthrotomy in the anterior capsule, open it up because every once in a while the pus is behind along the iliopsoas, and then do everything that he does.
Dr. Kumar, anything to add?
I think pretty much everything. The only thing is I make it sure that at least 12 liters of saline is used. So, so you start with 3 liters of wash, then you put betadine for 3 minutes, see the clock for 3 minutes, then you put betadine, hydrogen peroxide for another 3 minutes, and then another do a gentamicin infusion, wash for 3 minutes. So at least you're 12 to 15 minutes of wash, thorough wash. And it's very difficult to do, especially for a cementless surgeon to wait for so long on the table.
Yeah, Dan, that's a question for you. You see the list. Alberto did fantastic work about it and about the efficiency of irrigation solutions. Dan, in Mayo, what kind of irrigation solution do you use?
So it would probably be split. Some people would use just dilute betadine. Some people are going to use betadine plus peroxide. I think that either one's okay. There have been some concerns about peroxide in North America, so it's used more reluctantly because of some concerns about it. But nevertheless, I think those are probably the two. I will say that most of the protocols that people use are not evidence-based. They're sort of like, I think it might work and it seems good and it makes me spend some time doing it. So just remember that most of the protocols you're going to hear from the podium are not based on real evidence.
I think we have to consider that anything what we are talking about is not evidence-based yet.
That's part of the problem with a lot of infection treatment, right?
Yeah, exactly. That's why we do the consensus meeting. Govara, what's your solution?
We use the iodine. Yeah, the betadine 10%.
Betadine 10%. Dr. Henry, from your point of view, I mean, you're a specialist, and what would you use as a surgeon?
I would use what Alberto tells me, basically.
Sorry?
I would use what Alberto tells me. I don't have a clear opinion on this.
Vijay?
Betadine and hydrogen peroxide diluted.
Diluted. And Dr. Kumar?
I think betadine and hydrogen peroxide diluted, yes.
And Ed?
As in yesterday, full strength, 1-to-1, or a dwell time of 3 minutes based on the lab data, in vitro data.
Okay, so for all of you, no evidence, but consensus. Betadine, probably in combination with peroxide, is the best solution for performing any kind of irrigation during DARE. So here's a recommendation about the amount of DARE. So we recommended during the ICM 2018, we recommended exactly the same, 6 to 9 liters of irrigation with iodine. Another question, for you, Dr. Henry. After performing a DARE, how long do you administer antibiotics, or you recommend?
We give 6 weeks of high dose, usually intravenous, target at whatever's cultured out, and then followed generally 3 to 6 months of oral antibiotics.
6 weeks IV. And followed by
another six
two or
weeks.
3 weeks.
A total
IV,
of 3 to 6 months.
And then up to 6 months orals.
Exactly.
Same protocol in India, Dr. Kumar?
Yeah, I think 6 weeks of IV antibiotics followed by another 6 weeks of oral antibiotic, depending on the sensitivity. Yeah.
Any other protocol?
Same as first stage, same protocol as a first stage surgery, PGI.
So I'll say at Mayo, it's actually different. So it's 6 weeks of high dose antibiotic, either IV or in some cases oral. And then most cases of DARE, not all, but most will get lifelong suppression, assuming that the antibiotic used is non-toxic and tolerated by the patient. And we've reported the results of that, and our results in the hip are much better than the literature, and that might be part of the reason.
Yeah.
Not sure.
Absolutely, I agree. I mean, the recommendation during the ICM was 4 to 6 weeks, but this changed during the last years. It's 6 years ago. So today we know we have to administer a prolonged antibiotic therapy up to 6 months, as we've heard from the specialist, Dr. Henry. So, and I did everything. He was happy. Everybody was happy. After 2-3 months, he played tennis again. And after 6 months, he came back to me with new pain, signs of infection, CRP25, and we are going to talk about this after lunch. I wish you a great lunch. Please be back here 1:55. Thank you very much.